Very good evening, friends. Today we are discussing about carcinoma pancreas, tumor of pancreas, management, clinical features, investigation, and some important things about genetics, tumor marker, etc. Carcinoma pancreas is a very dangerous disease because incidence and mortality ratio is 1:1. It is the third most common GI cancer and fourth most common cause of cancer related death. It is what are the risk factor for CA pancreas or pancreatic tumor? Age. It is the disease of aged person, mostly age 65 to 75 years of age. Male to female ratio is 2:1, and history of chronic pancreatitis more than 20 years may lead to CA pancreas. Smoking is a very strong predisposing factor for the development of CA pancreas. Risk factor is the familial recurrent pancreatitis is the important cause of development of CA pancreas. Hereditary pancreatitis. It is also known as tropical pancreatitis. Is the cause of development of CA pancreas. There is some genetic theory related to the development of the CA pancreas. Most common mutation is the known as KRAS mutation. The most common mutation responsible for the development of CA pancreas or inactivation of P16 and P53 genes responsible for development of CA pancreas. We all know pancreas is a retroperitoneal organ. It is situated in the C group of duodenum and extended to hilum of the spleen and over the L1 vertebra, L1 L2 vertebra, and it is located in the posterior surface of stomach and it forms the important part of the stomach bed. The parts of pancreas. We can divide pancreas into three parts: head, body and tail. 65% cancer found in the head of the pancreas, 55% in the head of the pancreas, 25% the body of the pancreas, 15% in the tail of the pancreas and 5% remaining the periampullary carcinoma. Important thing about the periampullary carcinoma, the prognosis is good in case of periampullary carcinoma rather than say head of the pancreas or body of the pancreas. Histological type. What is the macroscopic features of pancreatic tumor? It is a very hard tumor, and 85% histological is the adenocarcinoma. Ductal adenocarcinoma is the most common type of CA pancreas. Ductal adenocarcinoma. Some cystic neoplasm also there is a most common is the mucinous cyst adenoma. Prognosis of the mucinous cyst adenoma is better than pure adenocarcinoma because the role of radiotherapy and chemotherapy is not good in case of adenocarcinoma. First I inform you, I told you that incidence and mortality rate ratio is 1. Once this cancer occur, that causing the death of the patient. Survival may depend upon the location of the tumor, extent of the tumor, metastasis, etc. What are the clinical feature? Clinical feature, most common clinical feature of CA pancreas is progressive painless jaundice. Development of the progressive painless jaundice with non-tender palpable gallbladder, because when CVD or common hepatic get compressed by the tumor, that causing distension of the gallbladder. But in case of obstruction of the CVD by the calculus, not causing distension of the gallbladder, it is called Courvoisier law. Anorexia, weight loss, unexplained anemia, vomiting. Vomiting is due to duodenal obstruction in case of locally advanced disease. In case of CA pancreas, sign is tea color urine, clay color stool, and pruritus in the body, because if carcinoma located at the head of pancreas, that causing obstructive jaundice. Other features: pain, dull ache pain and abdominal discomfort, and pain radiating to the back, because when tumor infiltrating perineurally to the celiac plexus, that causing back pain. Pain is very severe and not relieved by normal analgesic. For that type of pain, celiac plexus block is indicated. If CA of the pancreas located in the tail, it is manifested as a metastatic disease in the stage 3 or 4, when malignant ascites is present and hematological spread to the liver and lung and peritoneum, lymph node. So prognosis is worst in case of tail of the pancreas, because clinical features presented in the later stage of the disease. Now we discussing about the investigations. First, blood investigation. If CA pancreas located in the head, that causing obstructive jaundice, serum bilirubin, total serum bilirubin level is raised, especially direct, and serum alkaline phosphatase is raised, but there is a mild rise in SGOT, SGPT. So in case of obstructive jaundice, there is a increased level of serum bilirubin, especially direct. Conjugated variety of bilirubin is raised, serum alkaline phosphatase is raised, and important tumor marker, it is known as CA19/9. It is a tumor marker specific for CA pancreas. It is raised up to 200 unit per ml. It is a diagnostic for CA pancreas. Other investigation: ultrasound. Ultrasound is a non-invasive modality for diagnosis, but it is operator dependent. In case of gas and fat, it is very difficult to diagnose CA pancreas by USG. Experienced sonologist can diagnose, but can diagnose only huge tumor. USG can't pick up a small lesion of cancerous lesion in the pancreas. Investigation of choice is CECT. contrast enhance CT scan. We are for the diagnosis of pancreatic tumor, we have to follow the pancreatic protocol. Triple phase CT scan is the gold standard for the diagnosis of CA pancreas. Arterial phase, portal venous phase. So through this method, through this modality, we can pick up the small hypodense lesion in the pancreas. Other method are MRCP or ERCP. ERCP and MRCP, when we injecting dye, there is a double duct sign, because in case of CA head of the pancreas, distal pancreatic duct and CBD obscured and compressed by the tumor growth. So both common bile duct and pancreatic duct shows dilatation. It is known as double duct sign, is the diagnostic sign for the CA pancreas. EUS, endoscopic ultrasound. This is the modern modality for the diagnosis of carcinoma pancreas. Importance of EUS is that it is used for staging of the tumor. It is used for staging of the tumor, and EUS guided biopsy for the tissue diagnosis for the cancer of pancreas. Now we are discussing about the management of carcinoma pancreas. Carcinoma pancreas, first we have to discuss about the staging of carcinoma pancreas. Stage 1, when carcinoma limited to the pancreas only, and there is stage 2, when carcinoma present the pancreas, peripancreatic tissue, duodenum, but no nodal involvement. Stage 3, there is a same as a stage 2, but there is a nodal involvement, locally advanced disease. And stage 4 divided into 4A and 4B. In 4A, there is a involvement of the vessels, arteries and vein. Superior mesenteric artery, celiac trunk, portal vein, hepatic vein, they are also involved in case of CA pancreas. So in this stage, tumor is unresectable. When vessels, mainly when blood vessels, superior mesenteric artery, hepatic artery or celiac trunk is involved, the tumor is unresectable. Important point to know, involvement and infiltration of the portal vein is not a contraindication for the surgery. If there is a stage 3 or 2B, it is a borderline resectable tumor. So before going for surgery, we have to start new adjuvant chemotherapy. Most common type of chemotherapy used is the 5-fluorouracil, 5-FU, or newer drug is gemcitabine. Surgical management of pancreas. When the patient, when the disease is locally advanced or confined to the pancreas only, the operation known as Whipple's operation, in which pancreaduodenectomy, classical Whipple's. Now, treatment of choice is pylorus preserving pancreaticoduodenectomy. In case of Whipple's operation, after resection of CA head of the pancreas, duodenum, common bile duct, gallbladder. We have to reconstruct it. At least 4 anastomosis required: choledochojejunostomy, gastrojejunostomy, pancreaticojejunostomy, and for Roux and bile there is a jejunojejunostomy, so that enteric content should not enter the biliary tree. What are the complications of Whipple's operation? First is gastric outlet obstruction. Second one is GI hemorrhage. Third one is the pancreatic fistula and infection. In case of unresectable tumor, we have to give chemotherapy by 5-fluorouracil and gemcitabine. Purpose of palliation: to improve the quality of life of the patient. First, pain. Pain is a very severe and boring and constant features of the CA pancreas. No other analgesics are very useful for the treatment. For the pain management, there is a celiac plexus block. Celiac plexus block is the treatment of choice. If there is a gastric outlet obstruction, so we can, if patient is surgically fit, so we have to do gastrojejunostomy, feeding jejunostomy, or if patient condition is not fit, then we can put a metallic duodenal stent by the use of endoscope. Or there is a ribbing of the jaundice. For that purpose, the replacement of the CVD stent either through ERCP, or if ERCP is not possible, then percutaneous transhepatic placement of CVD stent also can be done. Pancreas, in case of chronic pancreatitis, CA pancreas, the exocrine function of the gland is totally disturbed. So we have to give lifelong, whatever the life, because the survival rate is not more than 6 months. So we have to give pancreatic enzyme, fat soluble vitamins. And important thing to know, if patient, a non-diabetic patient, suddenly develop diabetes, we have to suspect about carcinoma of the pancreas. So if there is diabetes, we have to manage the blood sugar level as per level of the sugar by oral hypoglycemic or insulin. That's all about the CA pancreas. Thank you. In next episode we will discussing about the GI hemorrhage. Thank you.